So, may I have your attention, please? So, we'll start the study of lower respiratory, mainly lung diseases, and we'll discuss the images. And always remember, after having your first contact with the cases, you study the slides carefully, then refer to your textbook on lung pathology, and then restudy the cases. I think this is the most proper way. So here is an autopsy, an image from an autopsy, and you see that when you open the pleural cavity, it is filled with, what is it filled with? It's filled with blood. That means because a major arterial branch has been cut, and you have all this blood filling the pleural cavity, and this is most often caused by an accident, a motor accident. Of course, there are some cases that perhaps somebody can be stabbed, and this is hemothorax, all right? So the patient died from all this hemorrhage, and there was not enough blood in his vessels, and so he had a shock. There are a hypotensive shock, and perhaps all this blood, when it is gathered within the two layers of the pleural mesothelial lining, of course it compresses the lungs, and the lungs cannot expand. This could be another cause of death. That means a profound hypoxia, because if all this blood fills the cavity, the lung cannot expand and take air. However, it is more probable that there was an exsanguination. All this blood was spilled in the cavity, and so we had a hypotensive shock. There are other causes that fluid is gathered in the pleural cavity. What do you think? Is there a way that when you have a fluid accumulation in the pleural cavity, how can you use a microscope and see why all this fluid has gathered there? What can it be? Mainly two types of fluid accumulations exist. One is inflammation, because if you have an inflammation within the lung, and that somehow, this is somehow transmitted beyond the layer, the mesothelial layer connecting to the lung parenchyma, then the inflammatory exudate gathers in the pleural cavity. Another cause is cancer. If you have a primary lung cancer or a metastasis and affects the pleural lining, the one that is in direct contact with the lung parenchyma, because as you remember, the pleural cavity has two layers, two mesothelial layers. One is contagious to the lung parenchyma. The other is on the wall, on the chest wall. So if you have metastasis on the pleural, cells shed in the cavity accompanied by fluid. What way is it to discriminate the cause of such a collection? What can you do? Yes?
You can aspirate some fluid.
You can aspirate the fluid so that the patient does not have the symptoms of dyspnea, because if there is an increased amount, the lung is compressed, as we have already said, so the patient has respiratory problems. So you aspirate the pleural fluid and you put it on the machine that it makes the, how is that now?
A centrifuge.
Centrifuge, and then you get and make a cytological smear. And you look at the cells. If you see polymorphs, macrophage, fibrin, These are signs of inflammatory exudate. If you see atypical cells in the fluid, it's cancer. So you have to identify the type of the cancer cells, and combined with the patient's history, you'll understand, does it come from the lung? Is it a primary lung carcinoma that has invaded into the pleural cavity, or is it a metastatic carcinoma? It has to do with the morphology of malignant cells on the cytological smear, and probably with the expression of specific immunomarkers, because that's the way we can discriminate between the different types of cancer. And sometimes the fluid that is gathered is, you see, like milky. It looks like milk. And that's why, that's because a neoplasm, malignant most probably, has occluded lymph vessels, and what you see as a milky fluid is what is in the lymphatics, all right? And that's another more rare cause of fluid collection in the pleura. Yes. Now, what do you think is abnormal in this X-ray? Which part? The left half or the right half? What do you think is abnormal? I agree, the left part. How, the left part of the image, what does it look like? What does it look like? It's very dark. That means that in this side there is more, what? So it is black, that means it has air. So there is a lot of air. So what's the question? Is there this increased amount of air from the lung, or is it from the pleural? Remember what we saw with the blood collection. It could be air collection in the pleural. How can you discriminate that? You see, of course, the ankle near the diaphragm. If the lung is filled with air, this margin down the septum will be flattened, because the lung will be full of air. If it is outside the lung, if the air is collected outside the lung, it won't be flattened. So have a look here and tell me, is this air in the lung or in the pleural cavity? What do you think? Look at the ankle. Look here. You see it's not flattened. You see? Remember how it looks like here, because in a few slides we'll see what flattened means. Just a moment. Have a look here. Oh, you see, have a look here at the left. This is flattened. So here the air is in the lung. That's why the ankle no longer exists. Is this clear? Have a look at this.
Isn't there an angle in the left side of the lung?
What?
It was like this.
Yes, the other had an ankle. So the air is from the outside.
Yes, I mean this one on the left side here.
Yes.
Isn't there an angle?
It is. The left side is okay. The left side is okay. The right side has the problem. Yes. Yes, what you see here. Here the problem is on the left side. You see? Where the arrowhead shows.
On the right side of the patient, though.
The right side of the patient, I can see the ankle.
In the X-ray, you don't use it on the left.
Yes.
The right side of the patient.
The arrow shows the right side of the patient.
Right.
That's where the problem is. Is that clear? Yes.
You say it's left because it's left as we see it.
I made a mistake. I made a mistake. The problematic side is the right side of the patient. Thank you for your correction. Everybody makes mistakes. That's not a problem. Not a problem, as long as the mistakes are corrected and they are not repeated. So, let's go back. Yes, please.
Can you please explain again
Why there is much air?
when is there in the lungs and when it's in the pleura? What's
The
the
pleura.
difference between
Yes.
the angles you said?
Here that the patient's right lung is filled with air, there is a flattened margin. You see? If the air is outside the lung, you don't see this. So let's go back to the previous case. Here we are. We have collection of air in the pleural cavity. That's why the ankle on the right of the patient is evident. You see the ankle? So, what consequences does this have to the patient? There is something compressing the lung. So, this is an emergency. And this is called pneumothorax. Where did the air come from? Perhaps there was some acute attack of asthma where the lungs were over-distended because the bronchi were constricted and the air could not circulate and leave the lung. Or it is an emphysema, that means the lung is filled with air, but the septum among the alveoli are broken, and so they cannot push the air to leave the lung. So, in any of these cases, and of course, the most common cause is trauma. So that pneumothorax is here established. So, what do? The patient has an emergency. What do?
You have to remove the air.
You remove the air, so you cut in a place. And what's the problem here? This is tension pneumothorax. That means it works like a valve, and the air enters the pleural cavity, but cannot leave the pleural cavity. It's not a simple pneumothorax. It works like a valve. So what you have to do? You have to cut in a place, and so that you turn the pneumothorax to a simple pneumothorax, and then you put a below drain, and you wait for a couple of days so that the whole procedure is normalized again. But what has this caused to the patient? What has this acute incidents caused to the patient? Look, which is the blood pH? What do you think? What is it? It's 7.55. What is this? This is alkalosis. And what do you do next? You look at the partial pressure of the carbon dioxide. What do we see here? It's low. What does this mean? This is respiratory alkalosis, because the patient took many breaths, and so this was hyperventilation. And what happened? The partial pressure of carbon dioxide is low. Yes, please.
I didn't understand, how do we go from a tension pneumothorax to simple pneumothorax?
Simple pneumothorax, yes. You stop it working as a valve, because if you cut it in a place, the air can leave, and it is not gather. So you solve the problem. However, so that a permanent solution is possible, you have to put a draining device. And when you see that there is no more air in the pleural cavity, you take it away. It will take some days. So this is respiratory alkalosis due to hyperventilation. Yes. Have a look at the levels of bicarbonate ions. You see that it is normal, meaning that it is not compensated. The respiratory alkalosis is not compensated because, as you remember, what is the pH pH is, you see here, the negative logarithm of dissolved hydrogen ions. Now, have a look here at the concentration of the hydrogen ions. Look at the proportion. In our patient, the partial arterial blood bicarbonate oxide is decreased. So, the hydrogen ions is also decreased. And what's the consequent? pH increases, because it's the negative algorithm, all right? When you have the concentration of hydrogen ions decreased following the partial pressure of the arterial blood on carbon dioxide, you have a diminished concentration of hydrogen ions. This increases the pH. So how can this be compensated? What can happen now? Either acutely, within a few minutes of the respiratory alkalosis establishment, or after 8 hours on a more chronic base. What must happen now? You see the proportion, and you have the partial arterial pressure of carbon dioxide, and what do you have down? What's the proportion? What do you have down? You see here the partial pressure of carbon dioxide, and here what is this? The dicarbon oxide. So in order that the balance is achieved, what must happen to this? To the carbon dioxide, what must happen? It should decrease as well, so that the proportion is no longer reduced. And what can this happen? On an acute base, it's happened by buffered solutions. On a chronic base, which organ is responsible for this elimination of bicarbonate ions from the blood? Which organ has to do with that? The kidney, of course. And what happens? Look, you study here the mechanism. You have a reduction of acid excretion by the kidneys. That means reduction of renal secretion of hydrogen ions, resulting in an increase in the loss of bicarbonate ions and non-reabsorption of all their filtered amount. So bicarbonate ions are decreased in the blood, and so respiratory alkalosis is compensated. So how do you diagnose alkalosis? You see pH and the partial pressure of carbon dioxide, and that would be respiratory. And you look at the levels of bicarbonate oxide, and you decide where is the problem. If it's in the first factor, you have respiratory alkalosis. If it's in the second factor, you have metabolic alkalosis. And depending on which of two is the primary target of the disorder, you see what the other one does to compensate. So in this case, the compensatory mechanism has not yet started. Why? Because the concentration of, look here, bicarbonate ions is not decreased. That's why it has not yet compensated. Is that clear? Yes.
Does
It depends on how many hours you find it. Because if there is a problem, you just have to do something and give him something so that the balance is done again. Is that clear from pathophysiology? Remember, I'm a pathologist, so only the basics. Don't ask me too much, only the basics. When you have internal medicine, you'll understand what is there for you to do to have this balance properly compensated. So, this was pneumothorax. Now, here, you see how the pneumothorax is treated? What is this? Have a look. How did we say that this device is called? This is a chest tube, taking the air out of the pleural cavity. That's how pneumothorax is treated. And if this is spontaneous, not related to trauma, it means that emphysema might be the cause. And this is emphysema. What do you think? You see that peripheral airways are distended, are full of air, because there is an imbalance in two enzymatic systems, protease, antiprotease. If you have an imbalance, protease activity predominates, and the septa among the alveoli are broken. So the air enters the lung, but cannot leave the lung. There is not enough pressure from the septa to send the air away from the lung. And so you can see that the lung has distended cavities, and most importantly, it is very soft. When you touch it, it is very soft. This is emphysema. And how will you understand that apart from the X-ray that we have already discussed with the flattening of the ankle in the patient's diaphragm? How do you understand that? Have a look at the pulmonary function studies. Forced vital capacity is somehow decreased. You see? Forced vital, the sending of air within the first second is more decreased. So the proportion between FEV1 to FVC is very low. This is the hallmark of obstructive lung disease, which mainly has three entities. One is bronchitis, where there is abundant mucin obstructing the bronchi. The other is asthma, where you have constriction of the smooth muscle and stenosis on the bronchi. These are mechanical reasons of obstruction. And the other obstructive disease is emphysema. In this disease, there is no mechanical problem, but there is a functional obstruction. Why? Because the septa are no longer intact and they cannot send the air away. So it is a form of obstruction, but not a mechanical obstruction, such as asthma and bronchitis. So this is the image, and which is the hallmark of obstructive lung disease. This portion between FEV1 to FVC is significantly reduced, mainly because of reduction of the amount of air you can send away in the first second. And of course, in emphysema, the total lung capacity will be increased. Why? Because there is much air in the lung which cannot leave the lung. Yes, please.
How do we understand it's a functional and not a mechanical? Is there, what
Yes.
value do we look
I guess. How can you discriminate whether the cause of obstruction is functional or mechanical? This will have to do with what you hear. Because if we have constriction in the bronchi, the air that passes through the obstructed bronchi wheezes. There is some sort of whiz when you listen. And sometimes it's not necessary to put the stethoscope. It's so evident. This is asthma. In case of bronchitis, it will most probably be a smoker, and he will excrete increased amounts of mucus, mainly every morning. He'll have a cough, a productive cough with mucin. So, and you see that on the long term, the diffuse capacity of the lung is affected, and this is why the DLCO is so low. That means this is a serious case of emphysema. Centrilobular, because it has to do with the anatomic location, the imbalance. Okay, I think we have discussed all this. Here is emphysema. Is the lung, is the right lung of the patient too dark? Yes. It has become like a barrel filled with air. And the angle we discussed in the diaphragm is flattened. So here we have air within the lung parenchyma. But I want you to see some other information for this patient. Have a look at the pH. It's 7.35. What does this mean? Have a look at the pH. Is it, I think it's low. So what does this mean? This is acidosis. So what will our next question be? Is it respiratory or metabolic? What will we have to look? We'll have to look at the partial pressure of carbon dioxide. Let's have a look at this. Pay attention, please. Pay attention. Not you. I come here, you start talking there. Everything becomes Greek as the lessons go. Everything comes Greek. I am here. You must listen to me. I think I shout enough. Pay attention. This is what you study. This will be your job tomorrow, all right? We're not theorizing here. I think you've understood that. Yes, please. So let's have a look at the partial pressure of carbon dioxide. It's increased, all right? So this is respiratory acidosis. Is it compensated? Who will tell us whether the respiratory acidosis is compensated? It's the amount of the bicarbonate oxide ion. Is it also increased? It looks to be. It looks to be. So there is compensation.
But it is within the range.
Yes, but it's the upper. So something is done so that there are signs of compensation. So that's how you'll study these cases. Now, yes, please.
How do we know if there is compensation if the amount of bicarbonate is in the range of the normal?
Yes, it's in the upper range, so it most probably starts. The compensation has started.
It's not clear.
Not clear, clearly, but yes, it's okay. You can hypothesize this.
And one more thing.
Yes.
In pathophysiology, they give us the range of pH 7.35 to 7.45 as normal. And you put
Here is another limit.
okay.
Don't pay attention so much to values.
Because here it would have been normal.
They change. I think, yes, it's low. It's a bit low. It's on the lowest normal limit. It's okay. And what has this caused in the lung circulation? If emphysema is chronic and of that severeness that we see here, what will happen to the pulmonary circulation it will be a cause of what? It will be a cause of what? Remember what we have already discussed in our circulatory system disorder cases. What will happen? If we have an emphysema for a long time, what will happen that will affect the heart, the right part of the heart? How did we say that? How did we say? Pulmonary hypertension. And will this have to do with the left atrium? No. So, the pressure in the pulmonary artery will be increased. Pulmonary hypertension. However, the wedge pressure will be normal because a primary lung disease is the cause of hypertension, not a dysfunction of the left side of the heart. Was that clear? Yes, when we have pulmonary hypertension, because you see here that there is a prominent right border of the card, this is a sign of hypertrophy. That means pulmonary hypertension has been established and the right side of the heart tries to send blood. That's why it is hypertrophied. Yes, the wedge pressure will be normal because there is nothing long in the left atrium. The problem is in the lung itself. And we discussed the successful compensation. You see? This hypercapnia, that means hypoventilation, decreased ventilation. It's the contrary of what we saw in the pneumothorax case. It's the opposite here. You see that? That stimulates renal hydrogen ion excretion and bicarbonate ion production and retention. So that's the compensatory mechanism. What are these cells being accumulated in the wall of this bronchus? What are these cells? Look, they have lobulated nuclei and their cytoplasm is too pink, is almost red. What are these cells? Do you remember them? We saw them in the last semester on inflammation. Which inflammatory cells are these? Lobulated nuclei, that means polymorphs, but not neutrophils because they are red. Their cytoplasm is red. What cells are these? These are eosinophils, and this is the allergic asthma having to do with eosinophilia. It's one type of asthma. And what is the hallmark of the disease? The smooth muscle within bronchi of a size that is considerable, not small bronchioli, they have no muscle component. In medium-sized bronchi, there is a signal and we have bronchoconstriction, all right? The muscle cells contract and the bronchus lumen is narrowed. That's why we have the wheezing of the air. And since the lungs are somehow over-distended, because there is full of air, however, it's not the case of emphysema. There is no problem in the septa, like in emphysema, but since the lung is over-distended, what complication may occur? Pneumothorax, like in emphysema. Because if there is much air, perhaps it may break someplace, and the air goes to the pleural cavity.
It's so easy to break. It's so easy to break that you might...
Not so easy, no, I don't say. Theoretically, it could be a cause. The most common cause of pneumothorax is trauma, as we said. However, there are lung diseases which predispose to pneumothorax. And what is the lumen of the bronchus filled with? What is this material here? Mucus. It's similar to bronchitis. But from a clinical point of view, You have to see how many, for which period did the patient had an early morning productive cough. There are some clinical criteria to diagnose chronic bronchitis in smokers. In asthma, these criteria are not valid. And in the asthma, you have the wheezing, which is very characteristic of this type of obstructive lung disease. Yes, please.
Can you develop metabolic acidosis from such
What can be developed? What?
metabolic, no, respiratory acidosis?
Theoretically, yes. Yes. You have to check the
Because you said for
the pressures and the pH. This is the other type of obstructive. And here is the mechanism. You'll study the cells involved in bronchoconstriction. CD4 lymphocytes of T helper 2 subtypes, mast cells which secrete histamine, of course, eosinophils which are quite toxic. Eosinophils are quite toxic to the local microenvironment. What has happened here? Have a look. Out of the lungs, of both lungs, the left one and the right one, what accumulation is this? What do you think? What color is it? Yes, but not so black to be air. So what can it be? Fluid. And it is bilateral, a fluid collection, which is a serous fluid collection. That means the content of protein is low. It's not an inflammatory exudate. So if you find such a serous collection of fluid in both sides of the pleural cavity, what do you suppose, taking into account what we have already discussed in our circulatory system cases study? How has this serous fluid gathered there? What has happened? Where is the problem? Yes?
Some type of edema, maybe because of
It's some
hypertension.
sort of edema, but is it the left heart failure?
Right heart failure.
That's the right heart failure. So the blood cannot leave the right heart to enter the pulmonary circulation. That's how you have increased liver, edemas in foot, distension of the jugular veins, and serous fluid collections in the pleural cavity. All these are signs of right heart failure. Okay? If we had left heart failure, we would have edema in the lungs, an increase in the blood within the pulmonary circulation, and if that would be so for a long time, we could have siderophags, that means macrophages with ferritin within the septa. These are the alveolar macrophages, and we would have increased pressure in the pulmonary artery, but since the problem is in the left heart, we would have increased wedge pressure as well. Okay? Is it clear and simple? I'm so glad, because it took me hours to study and make it this simple for you. Didn't understand? I had to study, because before I come here, I study myself. Yeah. And it's not because I'm paid for the lesson. I think you have understood that. It has nothing to do with that. Yes, please.
How would an edema look on the X-ray?
There wouldn't be any collection of fluid. However, you could see some diffuse linings in the X-ray, which would be the congested capillaries of the septum, where the capillaries are between the alveoli. Have patience, and when you'll do radiology next semester, you'll see the pulmonary edema X-ray, and teach me what it looks like as well. And what has happened to the lung? It's the contrary of emphysema. In emphysema, we had the lung filled with air. Now that both lungs are compressed by the serous effusion in the pleural cavity, they become atelectatic. This is atelectasia. That means without destruction of the septa and the configuration of the alveoli, they are too condensed. That means the space for air is very, very, very diminished. This is called atelectasia of the lung. It's the contrary of emphysema, atelectasis. Now, you can see this lung here. It has some bubbles, and this is called honeycomb lung, honeycomb lung. On a macroscopic level, it is similar to emphysema. However, it's right the opposite lesion, because emphysema is a form of obstructive lung disease. This lesion here is the opposite. This is constrictive lung disease. So, let's have a look at the pulmonary function measures. Have a look. The forced vital capacity is low. The amount of air within a forced expiration on the first second is somehow low. However, the portion of these two values, you see, it's increased. Let us go to the obstructive type of lung disease and make the comparison. So you tell me. Have a look at these three values here, and have a look here. In obstructive lung disease, this portion was decreased. Why? Because this value here was greatly decreased. In constrictive lung disease, this portion is increased. And what else? The maximal voluntary ventilation, that means how much air you can take and send away. In this case, it is decreased, and the total lung capacity is decreased. This is the opposite of emphysema. In emphysema, the total lung capacity was increased because there was too much air in the lung. Here, it's the opposite. And this is the hallmark of constrictive lung disease. And why is the air in the lung so reduced, so much reduced? Because there is fibrosis. And that's the difference between the honeycomb lung image due to fibrosis and the emphysematous lung. In the emphysematous lung, you have distended spaces, but the tissue is very soft because it is filled with air. In constrictive lung disease, honeycomb, that's the end stage of constrictive lung disease, you have distended spaces. However, when you touch, there is fibrous tissue. So it's not soft, it's hard. This is how you make the macroscopic differential diagnosis between emphysema, where the lung is filled with air, and constrictive lung disease. Have a look. And this, perhaps, this fibrosis is, in many cases, idiopathic, but in some cases that we'll see in our next lesson, there is a cause. We can find the cause of fibrosis. It's not always the case. Sometimes, no causal agent causing fibrosis can be found. And of course, on the end stage, the diffusing capacity has been greatly influenced here. And here is the honeycomb lung. You see? Honeycomb fibrosis and distal dilated residual airways. However, they have nothing to do with emphysema because this is constrictive lung disease. That means the fibrosis occupies a large portion of the lung, so there is not enough air because a lung amount of lung parenchyma has been replaced by fibrous tissue. So this is constrictive disease, diffuse pulmonary fibrosis, and in some cases the term diffuse pneumonia is used. When you listen, you see the term diffuse pneumonia, that means interstitial, diffuse interstitial pneumonia. It's not the pneumonia you understand normally. That means filling of alveoli with inflammatory cells. These are interstitial disease. And what will be the treatment? You should give the patient some antifibrogenic factors. And if the fibrosis grows, what solution is there for the patient? The transplant, yes. In about a 4 to 5 year period, a transplant should be found because there will be no other way to prevent the development of fibrous tissue. All right, see you now on Friday.